Okay, before we get started, we're going to take some vitals. Okay, so can I have you put this on your finger, and you're just going to let it rest right there. Actually, before we do that, do you mind if you take your scarf off? Okay, now we'll put this on. Thank you, and your hand rest. Do you know what your blood pressure is normally?
No, I do not.
Okay. We're going to find out. Probably most places you go will have an electronic one of these, but we make you practice with this one because technology fails all the time. If at your clinic, by the way, it's not a bad idea to bring your kits with you. Okay, because you don't know what your clinic will have. But if your clinic has, I think the stethoscopes that you guys have are pretty simple. Most of them are double-sided like this. And actually next module when we do cardiopulm, one is more for pulmonary and one's more for cardiac. That's why there's the two sides. One is better to hear lung sounds and one is better to hear cardiac sounds. Okay, so you actually can twist this depending on which side you want to listen to. So you always want to make sure that it's on the right side. So typically if you want it on this side, which is what we do for blood pressure, you don't want to see the hole there. And then if you flip it around, there's actually a little hole you can see on that side. And you can always tap it to double check. And which way should my earpieces be? Angled forward. Our ears go like that. Just go ahead and relax. Why did I hold her arm like that?
Heart. The heart.
Level with the heart. Technically, you're not supposed to take blood pressure with the arm relaxed at the side because it's actually going to make the blood pressure more because of gravity. So whenever you do blood pressure, the arm is supposed to be level with the heart. And what else do I have to document about her? How I did her blood pressure? Position. She's in sitting. Because blood pressure is different whether you're in supine, sitting, or standing. Why? Gravity. So of those three positions, when is blood pressure highest? Supine, sitting, or standing?
Supine.
Supine. It's going to be lowest in standing. Gravity pulls blood down to the legs. And if you're worried that someone does have orthostatic hypotension, you'll test it in supine, then get them up, wait 2 minutes, test it in sitting, stand them up, wait 2 minutes, do it again in standing. Okay, what do we have here? Okay. Can you place your right hand right here for me? And I'm just going to take your heart rate here. Okay, so again, usually the most efficient way to do it is 30 seconds heart rate, pretend you're still taking heart rate, and then actually watch their breathing for 30 seconds. Okay, so she's got 14 breaths per minute, 90 beats per minute. Everything normal so far?
Yes.
What's normal breathing rate?
12 to 20.
12 to 20. Some texts say 12 to 18. 90 beats per minute.
High.
Is this a true resting heart rate?
65 is.
Not really.
resting.
She's already been up for the day, walking around. Often patients tend to be like nervous in a medical environment, so it's normal for the vitals to be a little bit on the higher side. But yeah, it is a little high for a resting heart rate. I just checked mine with coffee, and you don't want to know what it is. Yeah, and if you've had coffee, that makes it spike up. Okay, so let's take a look at the shoulder. Do you mind if I move your sweater?
No, I do not.
Okay. So I'm going to go ahead and have you lie down with your head here. Comfortable? Okay, I'm actually going to take a look at this arm first. Is that all right? Okay. Why am I doing her unaffected side first? Yeah, you always want to compare affected to unaffected. Also, if it's the first time you're working with them, it gets them used to your touch without being on a guarded injured place. Okay, so any pain with this?
No.
How about there? Feel okay? That's fine. Okay, and if I was being really precise, I would be goniing it for real, not lying. Okay, do you mind if I move your leg?
No.
Any pain there?
No.
Okay. Okay, let's check out this side. Okay, if I was doing goniometry for shoulder flexion, where would my fulcrum be?
Greater trochanter.
Greater trochanter, stationary arm, midline of the trunk, because remember what happens to the thoracic spine when we go into glenohumeral flexion?
Goes into extension.
It can go into extension. So you really have to pay attention to the trunk position and that you're doing midline of the trunk, not parallel to the table. Okay, and then where is our moving arm? Line of the humerus to the... Yeah, because once we get over here, lateral will come down. Okay, because in general, most of the time with the moving arm, you want to know what you're lined up with, but then also what you're aiming for, because that'll change your precision. Okay, and if we were doing abduction, where's our fulcrum going to be?
Chromium. Chromium.
Chromium, head of the humerus. Sound good. Okay, stationary arm.
Across the racks.
Abduction.
Along the trunk.
No, same thing, midline of the trunk. Because if they have full abduction and full flexion, the end
It's all
generally
the same.
ends up looking the same. But you're holding the goni in a different position. Okay, so flexion, we're going to be here. Abduction, we're going to be here. And then how about for lateral medial rotation? Yeah, so electron on.
Yes.
And then where's our stationary arm going to be?
Pointing down or
So perpendicular to floor, but actually what can be a little bit more accurate is you actually want it in line with the humerus. Okay, because if I end up moving the humerus out here, that can look a little bit different. But yeah, it's essentially perpendicular to the floor. Okay, and then our moving arm, it's going to go through the ulna to the styloid process of the ulna. Okay, because we're on the ulnar side. Okay, and then same thing for internal. What else, to be really accurate, do I need to add to this? A towel. To have our humerus in neutral. So if you would just have your arm relaxed at your side, what position is your glenohumeral joint in? Slight extension. Does everyone see that? So here's the midline of the glenohumeral joint, and then the humerus is angled down. Okay, so just in this position, we're in slight extension, which will change your measurement. So that's why we put the towel underneath the distal humerus to keep it in neutral. Okay, elbow, what's our fulcrum?
Lateral epicondyle.
Lateral epicondyle, and then stationary arm, humerus to the humeral head, and then moving arm,
Along the radius.
radial side is the standard. The radial styloid. Flexion, extension. What do I have to do to measure true elbow extension?
The towel.
Again, put a towel because someone might have hyperextension. Which you don't have as much as I would think you do. Because you're female. Oh.
It's the bicep.
Because of those big guns.
Bicep.
Okay, and then for our wrist, flexion extension, what's our fulcrum? Which styloid process? The standard is actually the ulna. Okay, so the gold standard for measuring wrist range of motion is you're on the ulnar side. Okay, so I would actually, if I still had her in supine, I'd want to be on this side to do flexion and extension. Okay, I think one of the only reasons for that is because on the radial side, the thumb gets in the way of your measurement. So it's a cleaner measurement when you do it on the ulnar side. What else should I document about how I measure wrist flexion or extension? Yeah, whether I'm in supination or pronation, because that actually will change the measurement. Okay, and then how about for radial and ulnar deviation? Capitate. Does everyone remember how to find capitate? So find your third metacarpal, lock down until you feel it end. There'll be a little space, and then you're going to go into slight flexion, and you'll feel the bone pop into your finger. The bone popping into your finger is the capitate. Or capitate. As my instructor was. Lunate, hamate. Don't say that in the clinic, you'll sound really weird. Be like, where'd you learn that? Okay, so that's the capitate. So that means the standard for ulnar and radial deviation is in pronation, because that's the easiest place to palpate the capitate. Okay, and then one way or the other. It is unlikely that you'll do a lot of hand goniometry, but you never know. If there is a clinic that tends to do it a lot, they'll probably have one of those finger goniometers. Did you guys get one of the tiny ones? I don't think you did. Because there's so many joints in the hand, you just want to be really precise about which joint range you're measuring. So remember, you're always stabilizing the proximal segment, moving the distal segment. Okay, and in general, the fulcrum is going to be midline of the joint, and then along the proximal bone, along the distal bone. But remember not to skip segments. Okay, so I'm not going to be measuring it like this because I've got an extra joint in there. Okay, let's go over and if you can't recall this like as quickly as we're doing it now, practice. Okay, because CIs love to quiz you, and this is the easy basic stuff, so this is what they're going to quiz you on. Okay? Okay, so if we're going to measure hip flexion and extension. Okay, where's our fulcrum?
Greater trochanter.
Greater trochanter. How do you find the greater trochanter? Palpate and internally and externally rotate. When you internally rotate, it'll pop into your hand. Okay? Because again, add 300 pounds to her. That's your average patient.
Yep.
Maybe plus 200 is your average patient. Okay, so fulcrum, greater trochanter, where's our stationary arm? Again, midline of the trunk. So you really have to, not parallel to the table, midline of the trunk. Okay, and then where's our moving arm?
Along the femur.
Femur to the lateral epicondyle. Okay, and then we take her into flexion. True extension you have to do in prone. Same exact landmarks. What if we're doing hip abduction? This is where we go across. Okay, so the shoulder we don't go across, it's still midline of the trunk. At the hip, we have our stationary, well, first of all, where's the fulcrum? Okay, the ipsilateral ASIS. Okay, and then you're going directly across to the other ASIS. So again, it's helpful to find the ASISs and then ask your patients to put their fingers there. Because depending on what clothing they're wearing, sometimes, you know, you might actually line it up to like the line of their pants, and that's not their true line of their hips.
This helps you get a pinpoint of where it's at.
Yeah. Especially if there's someone where the landmarks aren't obvious. So you hold it across and keep it there, and then you're going to move your moving arm. Okay, so where should our moving arm line up? Femur to the patella. The humerus of the lower extremity to the patella. I know what you mean. Okay, and in general, it's easiest to do in supine, and you just move the opposite leg out of the way a little bit so you can go straight into adduction, abduction. Okay, so finding ASISs on a patient who has more mass than this. Okay, easiest way I like to do it, you want to use the heel of your hand. You're going to obviously warn them. I'm going to try to find the front of your hip bones. Is that okay? Okay, and then I just go here and I look for them. Okay, so you push into the soft tissue, but you're doing a broad, firm touch. So it's going to be less ticklish, less uncomfortable, and then it's easier for you to find, okay, where is it bony? Once you find where it's bony, then you can come in and hook up on the ASISs. But if you just go right in with your thumbs, you're going to be poking in a whole bunch. It's not going to be comfortable for them or you. So just broad hands, and you can find, no matter how big they are, you can find the bone, and then you can come up underneath it.
Works.
Everyone with me? Okay, what about hip internal, external rotation? What position do we usually measure it in?
Sitting.
Sitting, so let's do that for a minute. Okay, so where's our fulcrum going to be?
Patella.
Patella. And where's our stationary arm going to be?
Pointing to the floor.
Stationary arm. It's usually going to be perpendicular to the floor or pointing to the floor. Usually pointing to the floor is how it's done. Okay, and then pull in. I do the moving arm with it. Where is my moving arm lining up with?
Tibia.
Yeah, midline of the tibia to right between the two malleoli. Okay, so if I go like this, is that internal or external rotation? External rotation. So remember, don't get confused with the foot position. You want to think what is happening at the hip. And when I bring the foot in, it's because the femur is rotating out. Okay, because if I was to straighten her out, the toe would be pointing out. So really it's the direction the toes are pointing. If you get confused on that. Okay, and then that would be internal rotation. Okay, I also recommend that you be able to kind of just say off all the norms for ranges. And remember, plus or minus 5 is not significant. If you're in outpatient where you're going to tend to do measurements that need to be a little bit more precise, you may have a CI who's really like particular with what they consider the norm. Just go with it. Generally, in inpatient, you'll still have to do this, but you're going to be doing more gross measurements. The tiny little like differences aren't going to matter as much. That's another good reminder. Your CI is your be-all, end-all. Does not mean they're the greatest person in the world. Does not mean they know more than anyone else. But you are theirs for 2 weeks. Okay, so no matter, I mean, the majority of the time, things are great. Okay, you never know, like sometimes it's just a personality mismatch, but you're not there to be friends. You're there to learn something from them. And no matter who they are, they have something to teach you. Okay, so just keep in mind, no matter who you are, you got to swallow your pride a little bit and learn from this person. Okay? And again, not to freak you out. Majority of the time, CIs are awesome. But just remember that they're in charge. They might have learned things or do things a little bit differently than we've done here. That's normal in physical therapy. Even every like PT school does things slightly differently. Okay, so you're just there to learn whatever you can from that person. They are your mentor, but you got to do what they say. But if you really are miserable, please let us know. There's no reason to tough it out if you're miserable, because there are some situations where it's not appropriate.
That's good to know, because I'd be like, what do we just suck it up and go with it?
Yeah, and I made that mistake when I was a student and had a really bad CI, and I was like, oh, I'll just suck it up, and then I was miserable for 16 weeks, because it was my longest rotation. And I was stubborn, and I was like, I don't need anyone's help. But I could have used help in that situation. So we are your advocates. Do not hesitate to contact us. Sometimes we might tell you, you know what, tough it out, but if it's really bad, we'll try to put you somewhere else. Okay.
Cool.
Knee, go ahead and lay back down. Where's our fulcrum?
Knee joint. I'll see it.
Patella.
Well, what range of motion do we measure at the knee?
Flexion.
Flexion extension. So where's our fulcrum?
Right above.
Lateral epicondyle, not midline of the joint, lateral epicondyle. Okay, so then where's our stationary arm? Of the femur to the trochanter, and then our moving arm to the lateral malleolus. Okay, and you can do full flexion, and to do extension, just like with the elbow, we'd have to put a towel under here to see if there's any hyperextension. What happens if we measure knee flexion in prone?
It gets affected by the table. The table gets in the way. Unless you, when you're doing extension.
Not the hip flexor.
The hip is into it.
Oh, the hand
This
is.
puts the rectus femoris on stretch.
Yes.
Okay, so technically, to measure true knee flexion range, you have to do it in supine where the hip is flexed. Because then the rectus femoris isn't going to limit it. If you want to prove or test whether or not they have rectus femoris tightness, then you would compare your knee flexion range of motion from supine to prone. And if it's less in prone, that means the rectus femoris is limiting knee flexion.
Is there a normal variance between the two?
Not that I know of. I don't think they're supposed to be, because technically you should have a mobile rectus femoris. This is also called Eli's test. When you bring the leg up, and what you look for is, does the hip go into slight flexion? Most people it does, and then that would be a positive Eli's test. Again, positive for rectus femoris tightness. Okay, flip over. Okay, dorsiflexion, plantar flexion. No shoes when you measure it. Where is our fulcrum?
Malleolus.
Okay, lateral malleolus, and then where's our stationary arm?
Up the fibula.
Up the fibula to the fibular head. And then where's our moving arm?
Fifth metacarpal.
Parallel to the fifth. Ask your CI if they have a preference. My favorite way is to get it, the fulcrum and the stationary arm all set up and then drop it down so then it's easier to move, to keep the moving arm width parallel to the fifth metatarsal.
Would you drop it down to where that the moving arm is pretty much in line with the fifth metatarsal?
Yeah, that's how I like to do it. But then when you do that, you have to be really precise that you're not changing where your stationary arm is. Okay, and remember, it's not parallel to the bottom of the foot. You really have to palpate and know where the metatarsal is. Okay, because her metatarsal goes like this, which is a slightly different line than the bottom of the foot. Okay, and that will be the same for plantar flexion. Okay, what about inversion, eversion? Yeah, neck of the talus, which means halfway between the two malleoli. Or, I don't think we went over this. I'll you flip over. And so your feet hang off the edge. You can also do it from the back. And usually in this one, we find what's called subtalar neutral. So if you take, and again, if you're in an inpatient setting, you're definitely not doing anything this precise, but outpatient, you might learn this, okay? So it's okay to let them know, you know, we learned it measuring from the top. Can you show me how to do it measuring in prone? Okay? If you go to both malleoli and then come just off of them, so technically slightly anterior, and hold there, you're actually going to be holding either side of the neck of the talus. Okay, and then if I invert and evert, so when I invert, it pops into my finger on the medial side. When I evert, it pops into my finger on the lateral side. And I can find that point where I feel like they're equally touching each finger. Okay, and then if I hold the foot there, that's considered subtalar neutral. Okay, and you end up doing a fulcrum midway between the malleoli up the midline of the leg, and then your moving arm is going to go with the midline of the heel. And then you can measure inversion and eversion.
Easy.
Yeah, so you do it from the heel. So technically that would be calcaneal inversion and eversion. Fulcrum is midway between the two malleoli on the Achilles. Okay, and then midline of the leg to the heel. Okay, so that's just another option that you may see. Okay, so back